Um, so without further ado, we want to go ahead and get going. Again, welcome everyone. We're so happy you could join us. Happy Tuesday afternoon. We are very excited to have with us today Dr. Pamela Stedman-Wood. She will be presenting special considerations for veteran suicide prevention, end of life. I am also very happy to announce that we also have with us our dear colleague, Dr. Scott Shreve, National Director of Hospice and Palliative Care with the Department of Veterans Affairs, who will be emceeing today's webinar. Before we get started, just want to do a couple real quick little housekeeping tools. I know that many of you are familiar with Zoom. Those of you who are familiar with the VA platform, we do have a webinar chat box running along the right-hand side of the webinar screen. If you hover your mouse, if you are logged into your desktop, you do have the option to enter any questions or comments within the chat box, again, on the right-hand side of the screen. If you hover over the bottom, you also do have the option, you will see the Q&A box pop up. So if you have questions that you would like answered later on in the webinar or even perhaps at a later time, feel free to enter them there as well. I do also want to remind folks, I know I got quite a few queries. If for some reason you have to jump off early or you have a colleague who wasn't able to join us today, the webinar is being recorded and it will be posted online on the We Honor Veterans website. That's wehonorveterans.org under webinars. It will be up for free on-demand viewing whenever you'd like to view or listen again, and it should be up within the next week. Okay, without further ado, I'd like to go ahead and hand it over to Scott.
Thanks very much, Catherine. And just a quick shout out to Catherine and the National Hospice and Palliative Care Organization for our partnering in making this webinar presentation possible. It's really great to have the VA folks and our community hospice folks hearing the same content and being on the same call. For the VA people, just wanted to remind you, I'm not sure when the window closes to register for this within the VA talent management system, but if you need CEU credits for this, please go in to the TMS system and register. Get this training program assigned to you. It's number 3666, and that should get you there. Please remember to do that. I'm going to shift over quickly to providing an introduction to someone I've really just met virtually, and Dr. Pamela Stedman-Wood comes highly regarded by Dr. Michelle Carroll in the VACO in the program office, and it really just is wonderful that our paths intersected, and that with your background, a clinical associate professor in the Department of Psychiatry and Human Behavior at Brown University, also staff psychologist in a home-based primary care program. And it's so nice to have that blend of academics and familiarity with the VA system and our home-based primary care program, which has a lot of overlap in the patients and veterans that we care for in our hospice and palliative care team. So please join me in welcoming Dr. Pamela Stedman-Wood. Glad to have you.
Thank you, Scott. I'm glad to be here. I'm looking forward to talking with you all today on the work that we all do in working with veterans and dealing with end-of-life issues and suicide prevention. So today, I should also start out by saying, Scott, that I can't see the chat box at all, so if any questions come up, if you could just let me know at the end, and I'm going to try to run through the presentation and then save questions for the end. But if there's anything glaring, Scott, if you could interrupt me and let me know, I would appreciate it.
I will be happy to, and Catherine has instructed me, I'm going to monitor the Q&A box. If there's a simple question, like there's already one up there, how do I get a copy of the PowerPoint? I'm going to answer it during the presentation, but I'll try to keep a running track. If I need to interrupt, which I hope I don't have to do, but we'll keep a running track so I can try to organize the questions at the end, which will be great.
Wonderful, thank you so much. Okay, so today I'm hoping to discuss the valuable role of palliative and hospice care in suicide prevention, and then review our home-based primary care suicide prevention toolkit, particularly the special considerations training module on suicide prevention and end of life. And then I'm also going to run through a case presentation to illustrate an acceptance-based intervention for managing chronic suicidal ideation at the end of life. So it's got a lot of material to present today. And I just want to start off, as Scott mentioned, when we were briefly introduced, he introduced me to this public release by Don Sullivan that in May of 2018 this year. And Don Sullivan, for those of you that don't know, is an assistant professor of medicine at Oregon Health and Science University. And he's the core investigator at the Center to Improve Veteran Involvement in Care at the Portland VA. And his group wanted to see if palliative care reduced suicides among veterans with advanced lung cancer. And so in their research, they found that suicide is a leading cause of death in the United States, and that rates are increasing among veterans, and that the increased rates of suicidal ideation among individuals with advanced or terminal illness facing end of life, and that there are also increased rates of completed suicide among veterans registered, VA-registered, cancer patients, with the highest rates among those with lung cancer. And they found that VA-registered lung cancer patients who had at least one palliative care encounter after their diagnosis were 82% less likely to die by suicide, and that palliative care was associated with a reduced risk of death by suicide. I also wanted to provide some statistics from the National Veteran Suicide Database. This is the largest national analysis of veteran suicide rates. And this report was last updated in August of 2017, and it examines more than 55 million records from 2079 to 2014. And it provides data on veteran suicide by demographics, like age, gender, means, and a lot more information. It also provides information on the suicide rates of veterans in the population compared to non-veteran populations. And it also provides data on suicide rates among veterans who use the VHA healthcare system compared to those that do not. And it's interesting because what these data show is that the highest rate of suicide is really among our younger veterans, those ages 18 to 34, but the biggest burden of suicide is among older veterans. And so in our home-based primary care program here in the VA, we care for veterans who often have multiple risk factors for suicide. And these include depression, anxiety, chronic advanced illness and disability, pain, sleep problems, social isolation or lack of social connectedness, substance abuse, and cognitive deficits. So because we care for so many veterans with multiple risk factors for suicide, a group of HBPC psychologists in a quality improvement work group decided to start a project on suicide prevention, specifically for home-based primary care. And the purpose of this work group was to figure out what the current suicide risk prevention and management strategies were across VA or VA HBPC programs nationally, and to identify the most common challenges and barriers toward effective suicide prevention and risk management strategies. And then we wanted to develop interventions and resources targeting the identified needs so that we could improve suicide prevention activities in HBPC across the country. So, as I said, it was a group of all psychologists from around the country, and I just want to take a minute to shout out to Dr. Mlinek, Dr. Siffert, Dr. Richter, Dr. Wetherell, and of course, our fearless leader, Dr. Carroll. And together, we've were able to write a grant and get this project funded by a 2017 VA Innovation Grant, excuse me. And so I'm going to present to you the just a part of the toolkit, which is a staff training module on suicide prevention at the end of life. So individuals with advanced terminal illness experience a range of emotional reactions near the end of life, and death contemplation is quite common. And goals of care near the end of life, for example, advance directives, life-sustaining treatment orders, requests for suicide, change as individuals get closer to death. One of the major difficulties in summarizing and clarifying what is currently known about suicidal ideation in late life centers on the fact that there's little agreement about how to best define thoughts of suicide. Several attempts have been made to create a standardized definition of suicide. And the current nomenclature is that passive suicidal ideation, or thoughts of or wishing for death, are also referred to as death ideation, and versus active suicidal ideation, which is thinking or planning on taking one's own life. There are other meanings of death contemplation that are used in end-of-life communities of practice, such as desire for death or desire for hastened death. Many researchers have differentiated between passive and active suicidal ideation, and prevalent studies suggest that older adults are more likely to endorse passive ideation rather than active ideation, and that passive ideation is very common in individuals nearing the end of life and thus most widely studied. Passive ideation and thoughts of death may be distinctly different categories. So for instance, passive ideation or thoughts of wanting to end life versus thoughts of death, which is contemplation of end of life and how that might be experienced. Passive ideation among those facing end of life is associated with depressive symptoms, poor social support, and pain and suffering. And passive ideation and/or death ideation may also be normative at the end of life. Distress experienced by people with passive ideation near end of life is not fully explained by depression or other psychiatric illness. Distress at end of life may reflect the loss of dignity and/or meaning in life. And dignity and meaning can include multiple concerns of value for the veteran, including autonomy, respect, honor, preserving the sense of self and identity. And assessing these must clearly determine the nature of the death contemplation. So given prevalence rates of death contemplation in this population, it's important to provide a supportive environment to discuss feelings or wishes related to death and dying. Ideally, questions that are open-ended, curious, and non-judgmental can support the veteran in discussing whatever concerns are of importance. Some examples, conversation starters include, have you thought about how you want the end of your life to look? What is important to you as you approach the end of your life? What concerns you the most when you think about death and dying? And who else should we include in the conversations? End-of-life clinical discussions may differ when focused on suicide risk assessment. End-of-life clinical discussions require a careful balance of validating and assessing risk. And while important, interviews that emphasize traditional approaches to suicide prevention, which include suicide risk assessment and safety planning, may be perceived as invalidating. When we focus on the standard suicide risk assessments, this may pose a barrier to facilitating an open discussion around death contemplation. And it can sometimes seem as if we're setting a clinician-centered agenda for the conversation rather than engaging in a patient-centered approach that would encourage discussion of other concerns that may not reflect active suicide risk. So how do we best focus our discussions? When thoughts of death or suicide are determined to be passive or even normative, it's important to facilitate open discussions to examine those thoughts and provide individualized intervention. When thoughts of death or suicide are considered to be active suicidal ideation with or without a plan, intent, or means, traditional suicide risk assessment and safety planning are important. And the reality is that both of these approaches may be important to do together. Some possible interventions at the end of life are treatments that are designed to enhance dignity and meaning, and end-of-life care planning, which can result in decreased thoughts of death or suicide in individuals facing end of life. And discussions about values and acceptance can help individuals connect with what's really important to them and reduce suffering as they contemplate end of life. End-of-life suicide prevention should also include discussions related to fears related to death, minimizing pain and suffering, both existential and physical, planning for death, to include comfort care, hospice care, advanced directives, life-sustaining treatment discussions, dignity preservation, and relational work. Some of the barriers to having these end-of-life discussions can include discomfort that's experienced by veterans themselves, by staff members or other treatment providers, informal caregivers, and family and friends. And discomfort can even be a barrier to engaging in end-of-life discussions. So it's important to be aware of the reasons for avoiding end-of-life discussions. Some examples for veteran patients include inequitable access to health care and providers, or particular health beliefs about death and dying. Some examples for providers include different training backgrounds in discussing sensitive topics, cultural competence with working with the elderly, and even personal beliefs about death and dying can bias providers. So in addressing the barriers that we encounter in having these end-of-life discussions, it can be really helpful to consult with a palliative care or hospice services and spiritual experts to increase comfort in initiating these end-of-life discussions. And having team family meetings can also be useful to ensure that everybody has a mutual understanding of the veteran's values, priorities, and what the treatment goals are. So when we're looking at assessing suicide prevention, it's important to know that some of the motivating factors for desire for death at end of life include insomnia, physical pain, psychiatric conditions, including depression, anxiety, and hopelessness, and existential suffering. So loss of autonomy or dignity, a desire to have control over death, responsibilities toward loved ones, and even unresolved relational issues. And all of these should be evaluated in an assessment. There are a variety of different assessment or screening measures that can be useful to assess depression, anxiety, hopelessness. There's also a patient dignity inventory that's widely used in the palliative care community. And then there's a variety of decision-making capacity assessments as well, which I'll talk about a little bit later. Some additional considerations are that advanced directives may need to be updated, and life-sustaining treatment decision discussions may need to happen to include goals of care conversations and maybe even writing life-sustaining treatment orders. And referrals for palliative care or hospice care should be considered as well. So a brief word about decision-making capacity. There are times when individuals' decision-making capacity toward the end of life could be questioned. And if there are concerns about those abilities, there are a variety of different decision-making decision-making capacity evaluations that can be conducted. And in our HBPC teams, these questions generally come to our psychologists, and they typically come when there are when a veteran is refusing treatment, or whether or not the veteran can change their advance directives, or whether or not a veteran can engage in a discussion and completion of life-sustaining treatment discussions and orders, and also in requests for assisted suicide. So it's really important that when we have these questions about decision-making capacity, that A, we're doing an assessment, but B, we're making sure that all parties are involved in the veteran's care preferences, which at times means that we have to do a decision-making capacity evaluation, and at other times it means it doesn't. It could just mean that we're not all on the same page. There's a variety of psychotherapy interventions that are very helpful in working with veterans facing end of life. Those include dignity therapy and acceptance and commitment therapy. And I've added some links there to the particular website. For those of you that are outside of the VA, you probably are not going to have access to the second link, so I apologize. But I will make these slides available in the future. And I'm actually going to be talking about the act of letting go in the case presentation in just a moment. A few more resources. There's the APA, which is the American Psychological Association End of Life Issues and Care website. There's the VA Palliative Care website, and also the VA National Center for Ethics in Healthcare Life-Sustaining Treatment Decisions Initiative website. And so that completes the HBPC Suicide Prevention Toolkit presentation. And I want to just take a moment to also reference some recent VA trainings and initiatives that have been developed since this toolkit was disseminated. So we will be updating our toolkit accordingly with this new information. The first training I want to mention is the VA National Center for Ethics in Healthcare training. That it was a webinar that was originally, it was live on in August of this year on life-sustaining treatment decisions initiative, goals of care conversations, depression, and suicidal ideation. And what I wanted to mention here is this is, for those of you that haven't heard this, this is a fantastic webinar. And I actually put the TMS number there and highly recommend that folks in your spare time go ahead and watch this. There are some really great take-home messages, and some of the highlights I just wanted to mention is that the Life-Sustaining Treatment Decisions Initiative promotes proactive conversations with veterans with serious illness about the patient's values, goals of care, and life-sustaining treatment plans. And that the United States law and regulation, VA policy, and ethical consensus all agree that a patient that has decision-making capacity can refuse any treatment or procedure, even if that refusal results in death. That an informed decision to decline a life-sustaining treatment does not equal suicidal intent. That honoring a patient's decision to decline a life-sustaining treatment does not equal clinician-assisted suicide. And that when there is confusion or conflict about values, an ethics consult can help. So those are just some highlights from that webinar, but again, I highly recommend it. The second initiative that I wanted to bring to your attention is for those of you that are in the VA system, and even if you're not in the VA system, our community partners, it's important for you to know about this initiative. It's the new suicide risk identification strategy. And in May of this year, an informational memo was released to VISN directors, center medical officers, and mental health leads describing the plans to implement this standardized method for screening and assessing a suicide risk in VA. And there are a set of minimum requirements for the field. So this is medical center-wide in all programs. And the rationale behind this is that historically the VA has not had a national standard for screening, assessment, or documentation of suicide risk, and that the Veterans Health Administration and the Office of Mental Health and Suicide Prevention launched an effort to develop and implement a national standardized process for suicide risk screening and assessment using high-quality evidence-based tools and practices in all services medical center-wide. And there's a 3-stage process that's currently being rolled out. And there's a variety of webinars that are available right now, and they'll be coming out with CPRS templates and updating clinical reminders and training staff. So this is happening as we speak, and as I mentioned, we're going to have to update our HBPC suicide prevention toolkit to incorporate some of these procedures. Okay, so moving on to in my personal opinion, the most exciting part of the talk, which is the case example. Okay. So today, I'm going to be talking about a 78-year-old widowed Caucasian male who is 100% service-connected for bronchitis. He's a Korean War veteran, and he was referred to our HBPC program for advanced cardiopulmonary disease. He's oxygen-dependent and largely homebound. He was originally admitted to our service for routine care, and he was referred to me by his psychiatrist for psychotherapy for, quote, refractory depression, which is basically severe depression with chronic suicidal ideation that just was very, very resistant to treatment. And this was in the context of prolonged grief. As you can see here, I've listed his relevant medical and psychiatric history. You can see the list of medical diagnoses on the left side, and I actually didn't even include all of them. This is a pretty typical patient for us in HBPC. And so I will also point out, in addition to the major depressive disorder, he also was diagnosed with prolonged grief disorder, and he also had some cognitive impairment that really wasn't at the level at which we would diagnose him with dementia, but he was definitely having some cognitive changes. Relevant psychosocial history. He had an unremarkable childhood. He was the youngest of 12, an urban upbringing, quite impoverished, but a good childhood. He was an Army veteran, non-combat. And then as a civilian, he worked for a cable company, retired in the 1970s due to a back injury. He had been married for 47 years, had 2 children and 2 grandchildren. He was currently living in a 2-family home with his, in an in-law apartment. His daughter and her family lived downstairs. He had a very good support system. In 2003, his wife committed suicide while he was hospitalized in the ICU after a cardiac event with poor prognosis. So the family was told that he was not going to live, and the wife couldn't bear the idea of living without him, and she committed suicide, and he survived. He had difficulty ambulating due to poor endurance related to advanced COPD and CHF. He required assistance with his with ADLs. He had very limited social interactions due to poor endurance. And he had a pretty significant trauma history. In addition to his wife's suicide, he had several life-threatening medical crises and surgeries with very complicated recoveries, lots of ICU stays, lots of near misses. So the onset of his severe depression started in 2003 after his wife committed suicide, and he had no prior psychiatric history. He was treated for his depression for a number of years, 8 years, with combined medication and individual and group therapy that focused on grief work and stress management with some benefit, though he continued to have intrusive memories of his wife, particularly at night, that affected his sleep. His progressing illness prevented him from coming into outpatient appointments. And so, and then also during this period of time, he had several medical admissions for various medical crises with progressive functional decline. In 2006, he was hospitalized after experiencing extreme guilt for feeling like being in the hospital drove his wife to suicide, and he began having suicidal ideation, which was very severe at night, kept him up all night pacing, which you can imagine if you're oxygen dependent and have poor endurance was a challenge in and of itself. From 2006 to 2011, he had several psychiatric admissions for depression with suicidality, with plans to jump off a bridge, which is what his wife did, or hang himself. And a lot of these happened around anniversary reactions. So what would have been his 50th wedding anniversary, birthday, wife's birthday, and the anniversary of her death. So our work part one, when I first met him, and again, he was referred to me for this very severe depression and suicidality that just was really resistant to treatment. The first thing I thought of doing was suicide prevention and safety planning. So that's what we did. We talked a lot about his suicidality and how to prevent it, and came up with safety plans and included his family and the team. We tried to increase his engagement in pleasurable activities. As I said, he was pretty much homebound, and a lot of that was because the in-law apartment was upstairs, so it was very, very difficult for him to get up and down the stairs. We wanted to improve his sleep, and we did grief work, which was a little bit different than the grief work he had done in previous individual and group therapy. Our work together was ACT-based. So we were working together to help him learn to have a different relationship with his painful thoughts and emotions versus trying to get rid of them. And that's sort of what we believed was driving his suicidal ideation, is this real constant struggle or tug of war with not wanting to have these painful thoughts and feelings around his guilt, around his wife's death. And frankly, we weren't making much progress. He was a very compliant patient and did pretty much all of our homework and was very engaged in treatment, but continued to have this ongoing suicidal ideation, very low mood, very depressed, isolated, started to have more anxiety, and really bad sleep. So we needed to do something different. And so the second part of our work together, which I call the act of letting go, we decided to do a much more focused ACT intervention. And for those of you that aren't familiar with ACT, it's acceptance and commitment therapy. And acceptance and commitment therapy is an evidence-based psychotherapy that uses mindfulness and acceptance to improve the quality of life in spite of circumstances that don't necessarily change or get better. And it focuses on enhancing psychological flexibility by promoting acceptance of internal experiences. So those are our thoughts and our feelings and sensations. So being able to sort of accept what we call what's happening inside of our skin, and being able to take action or take steps toward personally chosen values. And using ACT with individuals approaching the end of life, in my opinion, really embodies the essence of ACT, because it's living life fully in the present moment, knowing that time is very limited and the present moment may be all that we have left. So in our work together, this act of letting go, this is what, in this particular case, we focused on these particular ACT core processes. So in terms of his values, we wanted to know what was important to him in the time that he had left. We wanted to help him accept his physical and emotional experiences versus suffering or struggling with them. We wanted to help him work on this idea of leaving a legacy, doing a life review, and to help him be willing to be present with uncomfortable experiences and take committed actions, which meant for him preparing himself and his family for his death. So we completed together 8 out of 10 weekly sessions. So the acceptance and commitment therapy protocol is a total of anywhere from 10 to 12 weekly sessions, and then booster sessions as needed. So we got through 8 out of 10 of them. And then the veteran was hospitalized for complications related to his defibrillator replacement and suicidal ideation. And he was discharged to a skilled nursing facility for rehab. And he was there for quite some time. And I will also say that I forgot to mention, but one of the things that was very distressing to this veteran is that every single time he was hospitalized, including this rehab stay, when he would tell family or providers, care providers, that he was ready to die, they put him on suicide watch. They put him on a 1-on-1 suicide watch. And for him, that felt extremely invalidating. And he couldn't understand why his family and his care providers couldn't just let him go. So he came back to our program after his rehab stay, and this time he was admitted to our palliative care service instead of the routine service that he was originally admitted on. He also started to have more symptoms of anxiety and panic, and we resumed our psychotherapy and re-reviewed his treatment plan and his goals. And we started with clarifying his values, what was important to him. So we asked these questions. And these questions are part of a typical acceptance and commitment therapy case conceptualization. So this is typically how we think about these cases, by asking this particular set of questions. So what value direction does this veteran want to move in? What is important to him? He wanted to prepare for a dignified and peaceful death. We wanted to know what was standing in the way of that. And we believed through discussions, I should also say that this is done very collaboratively between the therapist, myself, and the veteran. And what we came up with was that what he felt was standing in his way is that the family and his medical team's unwillingness to let him go was getting in the way, because we were all so focused on treatment and suicide prevention. And then we want to know what thoughts or rules is the veteran fused with, or when we say fused, we think about that as sort of like, I use an analogy of like a piece of fly tape. Like you have these thoughts and they just get stuck to the tape constantly and you can't get rid of them. And they just accumulate. So he had this thought in his mind, this recurring ticker tape that said that his family isn't ready for him to die. So he has to keep fighting for them. Now remember, this family had experienced a very traumatic death with his wife who committed suicide. And so they still were grieving all of these years later. And so he just felt like they could not possibly go through another traumatic death. So he had to keep fighting. And so they never really talked about it. Then we also wanted to know what private experiences or feelings is the vet avoiding. And we discovered that he had a lot of guilt for wanting to die because he was afraid of hurting his family, as we mentioned before. We wanted to know what unworkable action the veteran is taking. So what sort of behaviors was he engaging in that weren't working for him? And we discovered that he was really unwilling to share his wishes with his family, and that agreeing to be hospitalized and undergoing treatments was really against his wishes. And so we changed our treatment plan. And what we did was we did a lot of mindfulness and experiential exercises that helped him manage overwhelming symptoms of anxiety and panic and guilt. So the mindfulness exercises were a variety of different exercises just to help him get focused and get present so that he could be in a space where these difficult emotions or thoughts would come to the surface. And then we used experiential exercises, very much like exposure therapy, where we help him sit and tolerate the distress associated with those thoughts and feelings, rather than trying to shut them down or to avoid them. We also identified that continuing to focus on suicide prevention was contributing to his anxiety. He was really feeling unheard. And we explored his value of wanting to plan for a dignified and peaceful death, while respecting his love and devotion to his family. And we agreed that it would be a good idea to have a team family meeting to discuss his care plan to make it more consistent with his values and his wishes, which was essentially his acceptance of readiness to die. So our treatment plan transitioned from suicide prevention to planning for end of life. He set goals of care based on his wishes and values. So he wanted to be comfort care only, so no life-sustaining treatments, and no hospitalizations. We referred him to hospice, and in our HBPC program, we actually contract with community hospice providers. And all of this work was done as an integrated team approach with our HBPC team, which included myself, our social worker, our nurse, and the veteran's primary care provider, the VA outpatient psychiatrist, his family, and the hospice team. And the veteran received hospice care for 3 weeks with resolution of suicidal ideation, and he passed away peacefully in the supportive presence of his family. And his family was able to have a corrective death and dying experience. And I will share, for those of you that do this work, you probably can appreciate this. I don't often go to a lot of memorial services. I really use my discretion in deciding when to do that. But because we had worked with this family who was still grieving the loss of their mother and was really not ready to let Dad go, and we worked really, really, really hard to get them there, and there were lots of tears shed and lots of acceptance on their part, it felt really important for me to go. So I decided, myself and the social worker went to the memorial service, and as we were leaving, one of the daughters came up and stopped me and asked if she could give me a hug and thanked us thanked me for all of the work that we did together, and basically validated that we gave their family a corrective death and dying experience. And so it was just such a very special moment, and just really reminded me of the incredibly powerful work that we do in working with veterans in palliative care and end of life, and that this approach truly can be very, very important in preventing suicide prevention in this population, and really giving people, I'm putting in air quotes, control over their death, and not feel like they have to suffer in silence and take drastic measures that really ultimately can be harmful to themselves and leave a legacy of harm to those that care about them. So I thank you for your time and your listening, and I'm happy to answer any questions.
Sounds great, Dr. Wood. Thank you. I have a number of really good questions along the way. One of the earlier questions, I'm just going to kind of go through them mostly in order. I believe it was a chaplain who asked about the efficacy of chaplain visits in decreasing suicides.
Right. So that's a great question. I honestly cannot speak to the research itself because I'm not familiar with that literature base, but I do know that we use the chaplain service here in our HBPC programs, and I know that chaplain services are a very big part of hospice programs, and for many people, having that spiritual presence and counseling and guidance can be extremely helpful.
Yeah, I'll just add to that from a palliative care program perspective. We survey the family members of all veterans that die in our VA medical centers, and we have made the correlation that documentation of a chaplain visit prior to the veteran's death is significantly associated with increased satisfaction on the family perception of care. So I suspect there's a connection there. Early on in the first couple of slides, Jessica and another person were asking, you use terms like suicide rate and suicide burden. Can you expand on what you meant by burden? I didn't pick up on that, but a couple people had a question about that.
Sure. I think they were referring to, it was in the, let me see if I could go back here. I think for the statistics slide, I believe, yes. I believe this question refers to the statistics that the highest rate of suicides is among our younger veterans. So those ages 18 to 34. So the rates of suicide are higher in those younger folks, but the burden of suicide is highest among our older veterans. And let's see, we believe that due to the great numbers of older veterans, I think this is in part because, let's see, in 2015, there were over 58% of veterans who died by suicide over the age of 55. And we just know that the older veterans have so many more risk factors for suicide, and so that there's a big burden there. So while the older veterans aren't necessarily in the highest rate of completion, they're in the highest risk group. And we also know that for some reason, being an older veteran in the VA system is protective, because older veterans who are getting care in the VA system have lower rates of suicide, actually, overall.
Interesting.
I hope that answers the question.
Yeah, that's not it's a layered issue, and thank you for kind of dissecting that. Kathleen was I think just mentioning a comment that how financial distress can be perhaps a contributing factor to suicidality, in the sense of my family is better off if I'm dead. That, you know, I'm not costing so much money. I'm not requiring so much health care. I'm not burdening the family in a financial aspect too. And I've not seen much in the way of risk factors related to financial burden. So I don't know if there's any comments related to that aspect of risk factor.
Yeah, actually, I haven't seen that in the literature as an actual risk factor itself, but certainly this idea of, you know, feeling like a burden and can certainly contribute. I think the statistics, the issue of burden, when I presented the statistics, was not the actual emotional burden. It was actually the burden of risk, if that clarifies it at all.
Yes. Yeah. There's definitely a difference in the use of that word burden there. Good, thank you. Christine Brown brought up the issue of this comprehensive suicide risk evaluation form. I didn't realize it's evidently a 33-page form, and I think there was some concern, speaking of burden, that this form was burdensome. So I don't know that form or about its implementation.
Yeah, that's right. That could be an hour-long talk in and of itself. But just suffice it to say that it's really important, if you haven't already taken those webinar trainings on the suicide risk identification strategy, it's important to inform yourself about that, because there are minimum requirements that are involved, and there are actually three stages. The first is doing a primary screen, which is asking 3 questions. If those are positive, then you go on to the secondary level of screening. If a set of those questions is positive, then you do this comprehensive risk evaluation. And it's really only required once a year. And there are a lot of exclusionary criteria. So again, it's way beyond the scope of this particular talk, but the details are are fleshed out very nicely in those 3 webinars. So I would direct folks' attention to those if they haven't already participated in them. Were there any other questions? Hello?
Yeah, let's see. I think Scott was going through a few, and I'm just sorting through the Q&A right now. Let's see. I'm not sure the last one he... let's see, I believe this is more of a comment, but Art Hall replied, "Great stuff today. I'm a hospice chaplain and I will use much of this in working with families on a regular basis. What is unique to veterans as opposed to a non-veteran who would have suicidal ideation? If I had to guess, it would simply be the power of the ideation."
The power of the ideation. I'm not, can you speak a little bit more to what you're asking there?
Yeah, Bert, if you wouldn't mind maybe expanding on that comment a little bit, and we'd be happy to clarify. Let's see, I also have Sharita asked, what is the definition of corrective death and dying experiences?
Okay, good question. So it's this idea of having a corrective experience. So, you know, when an individual goes through a very negative or traumatic experience, it sort of leaves an impression in our brains and almost like an imprint. And it can in many ways it can dictate future behavior. So this is going back to like psychotherapy from like, I want to say 60s and 70s, but this idea of being able to have a corrective experience. So go through the series of events where the outcome is different. And that way it can help sort of reshape or provide a different feedback loop in our system, so that when we approach situations again that are similar, we don't face them with a lot of anxiety or avoidance or angst, because we've had this corrective experience. So when I was referring to the corrective death and dying experience, this family's whole view of death and dying was so negative and scary and traumatic because of the veteran's wife committing suicide and all of the events that surrounded that suicide, because the veteran himself was in ICU, potentially, you know, in a life-threatening condition. So when they were facing death again for him, they were very afraid of it and very fearful of it, to the point that they couldn't even have discussions about it. Everyone was sort of tiptoeing around this idea of death and dying, and that it felt so uncomfortable that they just couldn't even bring themselves to talk about it, whether or not that was the case. Because we found out that when we actually provided this safe space for everybody to talk about their fear of death and cry and, you know, and sort of move through that, they were able to process it and get to a place where they didn't like the idea, but they were willing to accept the veteran's wish to die and to stop fighting and to stop suffering. And so for them, his death was not traumatic. They were prepared for it. They were ready for it, and it had corrected that trauma that had happened previously. That was a very long-winded explanation, but I hope that answered the question.
And I want to apologize if you can hear me, Dr. Stedman-Wood. I was cut off.
Oh, no problem. I'm glad you're back.
Oh, thanks. Let me know if I should pick up, or if you're proceeding in some other way.
I believe, Catherine, did we get a response to the clarification of the last question?
Yeah, so Bert followed up with, how is the struggle of suicidal ideation different for a veteran and non-vet? And then added, I work with many people with the same struggles of our case study, and I've seen this in non-veterans. My question is how it is different or a greater risk with veterans. I hope this helps.
Oh, okay. So, you know, I think the struggles can be very similar. I mean, we're human beings, and I think we all share similar struggles. I think what's different for our older veterans is that our research tells us that they have so many more risk factors. So many of our veterans have, you know, multiple comorbid medical conditions and psychiatric conditions and cognitive impairment and psychosocial issues. So when we're looking at suicide risk assessment, we are constantly trying to weigh the risk factors against the protective factors, and hoping that the protective factors will you know, balance out any of the risk factors. And that's where we, you know, put all of our intervention in, focusing on the protective factors. Our veteran population has so many risk factors, which is different from the non-veteran population. And so that's what I think makes it a little bit more challenging, is that oftentimes the risk factors outweigh the protective factors.
This is Scott, and I was just wondering, I don't know the prevalence of a psychologist being readily available on many of the community hospice teams. And I didn't know if you had any, and it's a tough question, I don't know how to approach it from your presentation, but for the non-psychologist member of the team, and let's assume that we're not in what I'll call crisis phase, but there is a patient with suicide ideation. Any thoughts on on how to approach it. I heard meaning being brought up a lot, relationships, showing that the patient is valued, but I didn't know if you had any kind of recommendations for the non-psychologist member of the team to provide a supportive environment.
Sure. So again, I think, you know, any member of the team can certainly be helpful in intervening. And I will point out, I'm trying to get to it. I think, so on this slide, if you can still see it, the dignity therapy and the patient dignity inventory, I think that's a great place to start for people who, you know, are not mental health professionals. The patient dignity inventory is a set of like 22 questions that asks a lot of questions related to like burden and meaning and whatnot. So you can get a really good sense of sort of how distressed that patient is, where they're suffering, and where it might be helpful to intervene and to work on. So you can identify if they, you know, need more social supports, or if they just really need to do life review, which is just basically talking about the different challenges that they've had in their life, and what strengths and aspects of resiliency they've had to overcome those, and sort of how they're using those same strengths that they had then now to sort of face this last challenge in the last chapter of their life. So I would really encourage folks to take a look at that website. They have some really wonderful tools and information.
Excellent. I feel like we're a little bit beyond the top of the hour, and I don't know, Catherine, about your time frame to cut off here.
Oh, it's completely up to you all. If there are a few more questions that you wouldn't mind answering, feel free to go as long as you need to. We don't have a set cutoff. Oh, great.
I wanted to ask, and I haven't heard it mentioned during today's discussion about, I guess I'll refer to it as acute suicidal behavior, and have heard that there is an increase in suicides at the time of delivery of a terminal diagnosis. And I can't remember where I heard that from. I don't know, you know, the literature reference. Any comments about kind of how critical that delivery of a very severe diagnosis can be in the time after that?
Yeah, so you are correct that tends to be a high risk time for individuals when they get a terminal prognosis. And I think, you know, obviously there's so much fear involved in that, but it's also around this idea of you know, wanting to have control, right? When we think about our deaths, there's so much of it that feels out of control, and so much that's unknown, and it's very scary, and all sorts of questions and thoughts, you know, go through our minds. And when we are in a situation when we are feeling the most threatened, our instinct is to want to protect ourselves from that threat. And the ultimate escape from threat is suicidality. So in some ways it sort of makes sense that you know, you would have that thought, but that doesn't necessarily mean that, you know, people are going to act on it. But it's definitely something to keep in mind when someone has received a terminal diagnosis. And that's why, at least in the VA, I'm so happy that we have this life-sustaining treatment discussion initiative, so that we're actually talking to people much earlier in the disease process and following them along and discussing goals of care, and also updating those as the illness progresses, so that, you know, so that we're ideally preparing people at a much earlier point in time.
Very good. Just a couple more questions that I thought were intriguing. One related to your case, and Eliza asked the question about, you know, she wondered whether the case that you presented perhaps could have been referred to hospice earlier in the disease trajectory, and if so or if not, kind of how did that discussion play a part in the patient, family, and provider experience?
So the answer to that question is absolutely, positively yes, with 5 exclamation points. Yes, it absolutely could have been, but the veteran was not ready. The veteran was not ready. Yeah, he was not ready. He felt like he needed to keep fighting for his family. Again, because they had not been talking about this. They just felt like they couldn't talk about it. So it wasn't even on the table.
Okay. And the last one, and I don't mean to end on a question that I believe is impossible to answer in a few remaining minutes, and this is Maria's question. And she talks about, how does the presence of PTSD impact the end-of-life process in a hospice patient? And I don't expect you to answer that, but she has a patient who's experiencing some issues from his combat history. But I just wonder, just to get people started in the perhaps the PTSD realm, and the case that you presented, I took notice that it was a non-combat exposed Korean era veteran. So PTSD, any thoughts on how that might play in?
Yes. So, right. So clearly symptoms of PTSD can exacerbate when folks are facing end of life. It is the biggest perceived threat. And so a lot of things, a lot of triggers can show up during that time. So, what I will say is that the VA really espouses evidence-based treatments. So if the veterans have been through either exposure-based therapy or CPT in the past, this could be a good time to do, a little tune-up, a little bit of maintenance therapy with that. I will also say that doing the acceptance and commitment therapy work can be extremely helpful because in many ways it can be an exposure-based treatment, and we're also using mindfulness to help folks kind of sit with those triggering experiences and be able to work through them. So I don't know if it really matters what the trauma is, but being able to do exposure treatment in the setting of those triggers and those very uncomfortable memories or feelings or sensations or thoughts is really helpful. It helps people kind of get unstuck so that they can move forward and do the work that they need to do and achieve those milestones at end of life.
Very good. Catherine, I believe we're at a reasonable break point. I'm sure there are some other questions. Boy, Dr. Stedman-Wood, you've covered an immense amount of topics related to suicide prevention, and I'm very grateful for bringing it up. And for all of our community partners, this is an issue that VA has really taken on as a high priority, and I foresee that prioritization continuing for the ongoing years. So I appreciate the opportunity to share Dr. Stedman-Wood's expertise.
Thank you so much for having me. And Catherine, can I email the slides to you so we can make them available?
Of course, yeah. So again, the slides as well as the recording will be up on the We Honor Veterans website. That's wehonorveterans.org. under our webinar section, and this should be up within the next week.
Wonderful. Thank you so much.
All right. Thank you both, and thank you everyone for joining us. Have a great day.
Yep, great presentation. Thank you.
Thank you.